Welcome, everybody, to our 8th and final session of this webinar series on incorporating 988 as part of California's Crisis Continuum of Care. I'll introduce myself. I'm Sue Ann O'Brien. I'm the VP of Crisis Services Integration for RI International and a faculty member of the Crisis Now Academy. I'm joined today by Dr. John Draper. If you had the pleasure of hearing his kickoff in session 1, he gave us a great overview of history of call centers in this country, starting with the very early days of crisis hotlines and also the advent of 911 and where we are today in 988. He also joined us for session 2, taking us into a deeper dive along with Didi Hirsh. Matt Taylor is also going to jump in after John is finished talking. John's going to give us a great wrap up on what's coming up next nationally for 988. Matt Taylor from Didi Hirsh is going to jump in with the California perspective on what's on deck for the next year. And then I'm really excited that our Chief Medical Officer from RI International, Dr. Chuck Browning, will be talking about our peer-powered scale. You guys don't know what that is, but he's going to tell you all about it and how that can have an impact as you're planning out your crisis care continuum.
We've got a lot to talk about in terms of the challenges ahead. I know you all are living the challenges now. But we talk a lot about what 988 is and a little bit about what it will be, but what it's going to take to be what it's going to be is a bit of a mystery. And for how long? We have some ideas of what the challenges are, and some that will will rear their ugly heads later as we learn more about what the needs are of our consumers and the people who need help in our communities. But right now, I think we're pretty much at the infancy stage here. This is not just a cute little graphic, it's a real graphic. I think that even though SAMHSA says, and I do really appreciate SAMHSA's aspirations of like 2028, we'll have the crisis care continuum built out and ideally reaching in crisis stabilization facilities, some 90% of people will be covered by then, and 80% of mobile crisis services will be covering the population by then. I think we may actually be in for something more like a 3 to 4 times that amount further up the road, because it is quite a building that we are creating. And as we learn more and more about what people are going to need, we're going to realize that there are these kinds of challenges. And these are the most immediate ones right now. We know capacity challenges will continue to pressure us over time. We'll talk a little bit about that. The need for people to understand what 988 is, much less even hear about it, is a challenge that we'll need to address. And this vexing geolocation issue, which I'll talk a little bit about, is something that must be addressed sooner rather than later. And we've been focused very much, most recently, on the build out of the front door of 988. But behind that front door is a wild, wild west. That wild frontier of mobile crisis services and crisis receiving facilities is far from established. And some of those challenges we'll note as we talk in this presentation ahead. We may have it today, we may not have it tomorrow. It depends entirely on what the demand is and how that grows. How important resources are and funding them to keeping up. And we have seen in the last year dramatic displays of what happens when you properly fund crisis services. I mentioned this last time. I think in the second presentation, I noted this same slide, and you can see it may be familiar to you all, the incredible growth in answer rates for chats, texts, calls, especially chats and texts. And what's interesting again about chats and text capacity, when you see that 96% of chats, I think it's closer to 98% now, 99% of texts being responded to, those are being solely and exclusively funded right now. The chat and text services are by the federal government, because they want to make sure that those are answered, because the local capacity is not ready at this time to answer chats and texts. So basically the federal government says, okay, we're going to pay these 25 centers to do it, do all of it, and we're going to give them all of the money to do that. And this is what happens when you give them sufficient money at so it's now closer to 98% with chats and 99% with text. It's not quite as good with calls, even though there was a significant increase with federal funding in calls. It's because there is very spotty patchwork funding at various state levels. Some states are more ready, willing, and able to fund their centers than others. So hopefully that will change over time, and we'll talk a little bit about how that looks shortly. So this is that vexing issue that I was referring to. It's a bit of a merry-go-round where one day we have capacity and the next day we may not. And over the next few days and years, we're going to see a full campaign, media campaign. What you're looking at here is some estimates that Vibrant put together for SAMHSA, for a report that SAMHSA gave to Congress in 2021 for appropriations that said, if we had a full campaign, a media campaign, here's what we think that the impact on call volume and text volume and chat volume is going to be. And this is a 5-year estimate. And you'll see that there's little, those are multicolored bars there. And those multicolored bars consist of what would happen if baseline volume typically just goes up like it does every year. What happens if we increase calls due to more people calling 988 instead of 911 because they know about 988? And then there's the new volume, people that we are reaching with these campaigns. And we expect in the first year, about 9 million contacts. Now, that's an interesting estimate that we made back in 2020 and handed over to SAMHSA for 2021. What's interesting about it is that right now we're on pace for something in the neighborhood of 4.5 million contacts this year, and there's been no campaign. Well, if we have a full campaign, which we're on, just really on the precipice of having really soon, a national campaign, then this would suggest a doubling of it. And this is what we call the moderate estimates. It's not the high estimates, there's also low estimates. So this 9 million in the first year, we would say, is probably going to be, would estimate a doubling of what we would see with a media campaign. And that's starting to look pretty realistic to me right now. And after 5 years, we expect a lot more people to be calling 988 who would have otherwise called 911, a lot more people who might have called local crisis hotlines will be calling the 3-digit number, and just an overall greater awareness of the numbers. So we're close to 3 times the amount estimated for the first year by the 5th year. So we're going to need to keep funding these crisis lines. And these are just the lines, not the crisis care continuum. We've got to have a really varied strategy and a deep and wide strategy for funding our crisis care continuum. It's going to require federal commitments, state commitments. Everybody's got to own crisis and suicide prevention. It's happening in our communities, so locally and statewide, we should be responsible for that. But the federal government has also made it very much a public health priority, so they will own it too. And one way they're going to contribute, and they've been contributing, is through providing Medicaid prospects for funding core crisis services of the continuum. Now, this is a recent Kaiser Family Foundation survey of states of the Medicaid coverage for each one of the core crisis services. What you see in the dark blue tells you how many states are, in this case, 12 states, including District of Columbia, that are funding all 3 core services in part through Medicaid coverage. There's the less than dark blue, kind of medium blue, suggests that these states are 18 of them funding core crisis services, 2 of them, not all 3, with Medicaid coverage. And then the light blue, such as California, 1 core crisis service, 10 other states in addition to California, and there's 4 that are not funding them with Medicaid coverage at all. We expect that to increase over time. And crisis hotlines are not typically funded through Medicaid coverage, except through kind of bulk administrative payments from Medicaid, which some states have devised the means for doing. Where are we with state legislation to help fund crisis services across the 988 continuum? Here's the way it looks so far, and this is interesting because I showed this graphic about 6 weeks ago when I last presented, and the numbers have changed since then. At that time, there were 5 states that had a 988 fee, now 6. You got Minnesota. The other thing that's changed here is 8 states have strengthened crisis care insurance coverage, and before it was 5. So just in the span of 6 weeks, we've seen those changes. That gives you a sense of how mercurial the funding situation is, the landscape is for funding crisis services around the country. So what is the federal government doing? And again, I showed this slide a couple of, well, like 6 weeks ago, and things have changed since then. 6 weeks ago, there wasn't this new HHS funding that's at the bottom that I'll get to, but just to remind you all of the kind of funds that have already been poured into 988 by the government, which have been absolutely unprecedented. The Medicaid option for mobile services, that's probably where you're seeing that increase from 5 to 8 for Medicaid funded states in the last, in the previous slide, is a lot of them are availing themselves of the Medicaid option for these mobile crisis services that I've mentioned before. California has got about $150 million from the Behavioral Health Continuum Infrastructure Program, primarily for mobile crisis services. And they will also be looking for federal matching grants from the American Rescue Plan Act. The omnibus budget, which passed at the end of last year, increased the 988 budget by $390 million over the year before, to give you a sense the degree to which the federal government is all in on this, including an increase in state block grants like we haven't seen before. First time we've crossed that $1 billion threshold with a 5% crisis services set aside. And that is a minimum requirement. Some could actually fund more of that if they wanted to. And this is the more recent news from the HHS funding package of $177 million to states and territories to improve the workforce response, technology supports, infrastructure coordination, and support for underserved high-risk populations and communications. Also, additional funding for tribal populations and crisis center follow-up programs are there as well. But back to an omnibus budget, if you notice in that 390 million extra, the 501 million for 988, in that package includes a public awareness campaign. So that public awareness campaign is coming. And it's interesting, there was a Pew poll, a survey of adult Americans from just last month that asked the question, how do you know what 988 is and what its purpose is? And 13% of American adults responding to the survey said, yeah, I know what it is, know what it does. And the other 87% did not know what it is or what it does. So when they asked those people or told them, here's what it does, would you call? 7 out of 10 of them said that they were somewhat likely or highly likely to call. That doesn't mean they're all going to call in 1 year, but it does mean that if we have a campaign, there's likely to be a significant increase in calls. So keep your eyes out for this campaign. Haven't heard much about it. I know it's in the works. the way in which routing calls for 988 and the Lifeline works. When you dial that 3-digit number, it does the same thing as dialing the 10-digit number for Lifeline previously. And that is that it looks at the caller's area code and then routes the caller to the nearest Lifeline center to that area code. And of course, crisis centers and their coverage is mapped to area codes. We know what that challenge is for those of us who are in transit. I don't know how many people on this call actually living with the same area code their cell phone is. And people also are in crisis when they're traveling too. So really being able to get as close to the individual's location as possible is what coarse geolocation is. And that means it's going to try to locate the nearest cell phone tower to the individual's cell phone. That doesn't mean they need to know exactly where they are, but this is going to get us, in many cases, the ability to route to local crisis centers. Now, why is that so important? Well, the government, meaning both the federal government and the state government and county governments, have said, we're going to give funding to our crisis lines and to our crisis care continuum so they can respond to our people who are in crisis. And we're going to project their needs based on what we think the number of calls coming to us from 988. Well, if a lot of those folks are from out of state, you're paying for services that are not going to get people connected to your local mobile crisis teams, for example, because they're in another state. Going to make it very difficult for them to get connected to the crisis services that your state is paying for. And that includes the crisis, that's the crisis center's time too, to answer those calls from another state, which can be very difficult for them to find services for the individual. It certainly can be helpful for the individual and better than no call at all, but it does make it very difficult to connect the individual to local resources. And that is particularly a problem if the individual is experiencing a medical or public safety emergency. What happens if they've just taken an overdose? What happens if they have they are threatening to kill somebody with a gun right now? Well, that would require fine geolocation, which is different than coarse geolocation. Fine geolocation is finding exactly where the individual is. And that's particularly important if the person is unwilling or unable to tell you where they are. If the person is incoherent due to an overdose or accident, hangs up because they are going to kill themselves now, are going to kill someone now. We need to be able to find them. And the timing is everything. Now, what we could do and what we have to do typically now is tell the 911 folks, here's the number, or here's the IRL to the individual. Let's text if it's a chat, and then you try to find them. You geolocate them. Some are willing to do that. Some are not willing to do that. Some are able to do that. Some are not able to do that. And even if they are willing and able to do it, that takes time, and time is of the essence. So fine geolocation in those circumstances is really important. So right now, 988 is making a promise to connect people to the local centers to be able to get them local services. And in the event the person is at risk and could die, to be able to help them get the services they need to stay alive. We're making that promise and we're funding for that promise, but the lack of geolocation prevents us from being able to fulfill that promise in the way we'd like to. There's other challenges in the crisis care continuum that we're really attuned to. There's two in particular I'm going to focus on now before I turn it over to Matt. And that is the interoperability efficiencies and the care standards and best practices. There's two ways of thinking about the interoperability challenges. There's the interoperability from 911 to 988, and there's the interoperability challenges from 988 to 911. From 911's perspective, it would be really nice if they didn't have to respond to non-urgent behavioral health calls and just be able to transfer those over to 988 centers. Those take up their time. They can't and should not be sending police under those circumstances. Those should go to 988. There's a few ways to do that, and a number of crisis centers around the country have been innovating, a number in Texas, in Los Angeles. They're working to do this, but co-locating crisis centers at public safety answering points, or just finding ways to dispatch mobile crisis services directly from 911. There's also the need for 911 to be able to communicate to 988 in the event 988 makes a call to 911 about the disposition status. What happened when 911 dispatched ambulance or law enforcement? 988 needs to know this, because in the event they didn't make contact, which frequently occurs, you'd be surprised how often dispatches don't actually make contact with the individual that 988 is so concerned about. But 911 needs to have a means of letting them know whether or not that contact occurred. If that contact did not occur, then 988 can follow up and send a mobile crisis team, for example, to check on the individual. It's also important, as I mentioned, that 911 at times may want to and be able to generate a mobile crisis response directly from dispatch. They might be able to, and perhaps should be able to, send co-responder teams. So police who are responding to the mental health emergency are trained in working with mental health emergencies specifically, and also have a mental health professional with them. And also the ability to directly transfer to mobile crisis team dispatch providers is certainly being talked about in a number of 911, a number of regions that are exploring ways in which to dispatch mobile services. Challenges between 988 and 911. Right now, there needs to be a seamless interface for 988 behavioral health emergencies to 911. And the ability, as I mentioned, to follow up on disposition status of the 988 generated referrals to 911. And we also need to do have collaborations with 911 to train them how to work with and maintain engagement with people who are in mental health emergencies, as long as they're calling 911. And as I mentioned, 988 mobile dispatch directly through call center or through the external entity is a question. 988, should they be directly dispatching mobile crisis services from the crisis centers? Many believe that that makes a whole lot of sense to do that. It's much more efficient for the individual who's needing mobile crisis services rather than be transferred to an external entity. On the other hand, if people are calling 911 directly, should 911 in those circumstances when they are called be able to dispatch mobile crisis teams? These are all interoperability challenges and questions that have not fully been answered. Another area of challenge for us is the existence of standards of care. Now, we have standards of care for crisis helplines. They've been established through years of evaluation of how it works with crisis hotlines, what works, what doesn't, and how to make them better. And those standards help provide some uniform baseline for all operations who are dispatching mobile, who are listening to people and determining whether or not they need crisis services of some kind, or they can receive an outpatient referral, or that kind of thing. The risk assessment standards were established through a consensus of experts back in 2007, and those led to the next question. Now that we know if a person is at risk, what do we do to help them? And in those circumstances, the Lifeline policy for helping callers at imminent risk of suicide was established, and most recently, these have been updated to the Vibrant Lifeline. The 988 Lifeline, and so it's Suicide and Lifeline Crisis. What is it called? It's called the suicide and lifeline suicide safety policy. That's what it's called. So that's the new policy, the new standards, which have been around for a while, that have been updated and upgraded. But what is there for mobile crisis services? There is very little to no standards for mobile crisis services. What should be the response time? Should it be different for rural areas? Should it be different for urban areas? Should it be based on what the individual's needs are? Maybe they're not going to be available in the next 60 minutes when many people are being asked to respond. Assessment standards. There's a lack of assessment standards for mobile crisis services. Right now, we do have assessment standards for harm to self, but not necessarily for harm to others, or specifically what standards should be used for assessing the individual's ability to take care of themselves in spite of their mental illness. And another area that we want to make sure that we are assessing or we are addressing is the quality standards for mobile crisis. What works? What should they be doing? And how are we going to be monitoring whether or not our mobile crisis teams are conducting what we know works in the field? And additional areas, not knowing how to train for best practices. Once we've determined what works, how do we train for that and provide a baseline uniform training for all mobile crisis staffs across the country? And also, what are the functional capabilities that are required of teams? If we learn more and more about the importance of peers in mobile crisis services, how is it that they should be deployed? And what should be their function specifically? If we learn that medication perhaps is going to keep people out of hospitals and in the community, should we also have psychiatrists and medication prescribing capabilities on teams? And then the other two areas to note is, in the event we're going out as a mobile crisis team, we need to know how safe it is. What are the staff safety practices that not only once we know what the safety situation is, how do we address those, or how do we engage police to, as I said that, you might hear police in the background. So the staff safety practices also need to be uniform and established. And finally, should there also be dispatch levels that are uniform for all mobile crisis teams around the country, that are really based on how safe it is for not only the teams to go out alone, but most importantly, how safe the individual is that they're seeing, the degree of risk involved. But none of that right now has been standardized across the country. So these are among many of the challenges we face at the national level. We certainly face them at the local level. And I am delighted to turn this over to my old friend and colleague, Matt Taylor, who's going to be helping us to address some of these major challenges in California.
Thank you so much, John. I guess one of the things that I would like to share with all of you here, sort of as you close out the series, is that things are presently looking good in California. There's a lot to be confident on. There's a lot to be proud of. And that does not mean that there's not significant rooms for improvement and enhancement. But over the previous weeks, you've heard about the range of services that the Lifeline member, 988 member contact centers in California, the services that they provide, not only for 988, but also, for example, for 211, for youth crisis lines. Some of them are providing services in the substance abuse space. A few of them can actually engage directly with mobile crisis. So you've heard a lot about their sort of diverse portfolio, but what you may not have heard of is what are the KPIs and the performance of the network as a whole right now, as of today. And this is why I want to share that there is a lot to be celebrated. So we know, for example, that there has been a volume increase in calls, chats, and texts across the nation. Let me just put that in perspective for California. So if we look at the last month, May 2023, we had just about 30,500 calls come into 988 from California. That represented about 12% of the entire nation. In fact, California is perhaps by no surprise the state that generates far and wide the most volume into the 988 network. The next closest state would be New York, and California generates twice the number of calls as New York. Then if you go down the list, it's Texas, Illinois, and Florida for the top 5 states generating volume into the 988 network. So again, California had essentially 30,500 calls that came in last month. That's a 21% increase from May 2022, just before the official launch of 988. And what I'm really proud to say is that the 12 centers that make up the California 988 network presently do an amazing job of answering those contacts. Our in-state answer rate for 988 calls for the month of May was 91%. And that is very significant given the dramatic volume that these centers handle. There was a 91% answer rate. The average speed to answer for the 988 calls was 30 seconds. And we know that the benchmarks we need to get to, as laid out by the Health and Human Services and SAMHSA, and even by the Department of Health and Human Services in California, the KPIs are higher, they're faster. We want to get to a place where 90% of all contacts are being answered within 15 seconds or less, and 95% are being answered in 20 seconds or less. So I said that our ASA, our average speed to answer, is 30 seconds right now, so we've still got a little ways to go. And that's one of those areas of improvement that the centers are working hard to achieve. How are they doing that? Well, first of all, they're doing what they can to hire more staff, and we're looking forward to hopefully increased levels of funding that are going to come directly from SAMHSA in a new round of 3-year capacity sustaining grants. We're also, of course, looking to the application of the 988 user surcharge in California, which for the first 2 years, the surcharge amount is set at about 8 cents per line, not to increase beyond 25 cents per line, 30 cents a line moving forward past 2025. So there are going to be significant revenues flowing into the California 988 network, and some of those are going to go to the 988 centers for the purposes of hiring more staff. The centers are also looking to improve their average speed to answer by analyzing the length of the calls or chats or texts. And what can they do from a clinical training standpoint to encourage their counselors to better find that balance when it's appropriate for closing a contact early when safety has been established, a safety plan has been created, and a full safety assessment has been completed. That way the counselors can move on to the next call. So that's where 988 is at presently in terms of calls. Let's talk about chat and texts. So when we think of chats, there has been almost a 40% increase in the chat volume to California in May of 2023 compared to May 2022. The volume is still, relatively low, but it's not insignificant. There were about 6,500 crisis chats that originated from California last month. And this is an area where we can stand to improve further services, because only 22% of those were able to be answered by the California centers. The rest rolled into a national backup provided by Vibrant. The good news is for those contacts, the chats that could be answered, they were answered in 9 seconds. Now let's talk about texts, crisis texts. This is a relatively new modality for 988. And in this case, we see over a 600% increase compared to where we were just before the launch of 988. And that's because there was some texting actually occurring before the 988 launch, but it's become much more official and much more publicized since the 988 launch. And so in this case, we had just over 8,000 texts in the month of May, 25% of which could be answered within California, and a 20-second average speed to answer. So what does this mean? It means that the 12 members of the California 988 network are looking to dramatically expand their coverage and their staffing for chats and texts. We have a requirement in state that all centers provide at least 8 hours of coverage 7 days a week for chat and text by next month, and 24-hour coverage 7 days a week by this time, essentially next year in 2024. So there's further build out in the staffing that is necessary for chat and text. The other areas that we really are looking forward to touch on some of the points that John was really mentioning. And the biggest one is further integration with mobile crisis teams and the ability for the Lifeline 988 centers in California to have direct access to whoever has the dispatch authority for the mobile crisis teams. And one of the things that is significant in California is that the Governor's Office of Emergency Services has been working to implement and roll out a unified platform for call, chat, and text handling, as well as a CRM platform on which the data is managed. And that is in process right now. And the estimate is that all of the 12 centers in California that make up the 988 network will be live on that platform by the end of the year. And one of the big steps is not just getting on the platform and not just figuring out how the efficiencies of that can improve our answer rates and speed to answer, but the other major component of this platform is how can we build out a stronger, more robust referral network, especially, for example, if you're a center in San Diego and for some reason you've just received a 988 contact from someone up in San Francisco. So you need to answer that contact, that call, that chat, that text, do a full safety assessment, provide some referral resources, and you need access, real-time access to a robust referral database network. That's being comprised currently within the 988 network and will be embedded into this new unified technology platform. But that's one area of referral. Obviously, as John has noted, one of the most critical areas of referral is into the mobile crisis teams. So there are multiple efforts underway to do a full statewide assessment of where those mobile crisis teams are, who has dispatch authority, how strong their relationships are with the existing 988 centers, and what is needed moving forward to more formalize those relationships. When I think about what's next for California and 988, it is about that workforce development. It's about building consistent and robust workforce management tools at the centers so that the projected volume for 988 calls, chats, and texts matches the staffing, and that's done in sync with any efforts across the state to further promote and market the 988 services. The other obviously big point, as I've just mentioned for the future, is integration with mobile crisis teams, and then of course, crisis stabilization referral units. This is a multi-year vision, but what I want to project in the summary that I've just provided is that we have a strong network now in California. It's one of the strongest in the nation. We have incredibly high answer rates, incredibly dedicated and high-performing counselors at the 12 centers, and we're very much looking forward to the future as a strong network to provide better services for those in crisis. So thanks, Sue Ann, for the opportunity, John, for the great setting you set up there in terms of the bigger picture of the crisis continuum, and I'll turn it back to Sue Ann and Dr. Chuck.
As part of this 8-session webinar series, we've created 3 takeaway tools for you that we hope are going to help give you some ideas, some guidelines on incorporating 988 into your crisis continuum in your community. One of those tools is the peer-powered scale. And Dr. Browning was instrumental in this development, and I'm going to hand it over to you, Dr. Browning.
So I appreciate you letting me be able to share this tool. I had the pleasure of working on it with Lisa St. George, our former VP and lead of recovery and peer support at RI, and worked together with that as well as other leaders in our peer leadership council to develop this as an organizational self-assessment tool. And so we call it the peer-powered scale, and we modeled it after really some of the other toolkits that are out there to help look at organizations for self-assessment, such as like the Zero Suicide Toolkit. And so we created kind of 3 areas of measuring yourself as an organization to see how peer-powered you are. So first of all, let's just define what is peer powered. So peer powered in our definition is this concept of, as an organization, in your culture, your leadership, the way that your entire staff works with with the people that you serve, as well as having kind of tools and systems that help you work towards that in a peer powered way. That's kind of how we define that. Being the intense, not intense, what is the actual definition in the essential care practices of SAMHSA's crisis toolkit is the significant use of peer support, recovery-oriented practices, trauma-informed care. And so it's not necessarily, if you haven't done that or had that indoctrinated or is embedded in your practice as an organization, it's a tough thing to pull off. And so we created this tool as an easy way to rate where you are as an organization, as both in the questions as well as recommendations that come at the end of your score can help drive quality improvement towards becoming more peer powered as an organization. So if you can see, this is an example. On the website, it's completely interactive and has the questions where you can just answer them and enter them in, and it scores them for you. And it's scored on a scale of 0 to 5 in 3 major categories. And that is going to be in peer culture, peer powered practices, and then peer powered systems and tools. So there's 5 questions about peer culture in your organization, 5 questions about peer powered practices that you use, and then kind of 3 points about types of tools and systems that you would want in place in relation to trainings, key performance indicators, ownership of that at the level of your organization to measure and manage the way that you're doing things from a peer powered perspective. So in those first 5 questions about peer culture, it's all about, it's not just the number of peers, but it's like what's the voice of peer support and peer leadership in co-design, in leadership roles? Do you have tiers of being able to move up and down within the company structure? So it has a lot about that, like what's the voice, the culture, and the involvement in leadership of what you're doing as an organization. That's about peer culture and voice. The second session is about peer-powered practices, and we've identified 5 main categories that we really use. And here's the important thing is that these peer-powered practices, our goal for the tool is to not just help a peer support person be able to carry out these practices, but a nurse, a licensed clinician, a doctor, a nurse practitioner, anybody that's on your staff working with people in crisis, just kind of 5 big picture ideas and thoughts about these are peer power practices and this is how you would use them. And so they're collaboration, because in crisis care, it's so easy to do things to people instead of doing it with them. So it's different viewpoints on how to measure how well you're doing that in being truly person-centered and collaborative. It's strengths focused, because again, in crisis, a lot of times everything gets focused on what's wrong. And so many times improving a crisis, and this is just modeled over and over again by the power of peer support, is it's working on what strengths you have and being empowered to get back to using them can be a big point in recovering from your crisis. Third thing is whole person wellness. So it's looking at your health, your family and supports, social determinants, all these types of things are put together when you come into a crisis situation. It's not just a diagnosis or your symptoms. And so all staff being able to think about it in that principle. The fourth is no force first, which in regards to 988, we always are thinking about how can we collaborate with this person to help keep them safe, but have the least restrictive intervention that's the least forceful. And that goes all the way up to even like crisis centers where you're working on seclusion and restraint and making that a no force first situation as well. And then the 5th one is trauma-informed care. And that's based on SAMHSA's trauma-informed care guidelines and looking at where are you with that? Because a lot of people say that they talk about what trauma-informed care is, but this tool really helps you grade, are you truly doing these things with all of your staff or not? And then finally is the tools and systems, which looks at, do you have some kind of organizational scale that you're using to track, and are you meeting on it fairly regularly and discussing where you are with it? Do you have different trainings to help support all 5 peer-powered practices? Do you have key performance indicators and dashboards and systems to look at those dashboards to see how well the people that you're serving are feeling about your being collaborative and being whole person's care and those types of things? So When you put all that together, you get an average score for each category, and then you get a total average overall score. And then it connects you to a lot of different references and recommendations that you may want to consider if you want to look for resources or referrals, or actually get help in how to do that. Because many places that's something they would like is some guidance or consulting on that. So it's on Crisis Now Academy's website. You can feel free. All you have to do is enter in an email, and you can either choose to be contacted about it or choose not to, but it lets you just do your own score. And I would recommend, if anybody that wants to use it, you can do it individually if you know about these elements in your organization, or sometimes we'll get, a focus group of different folks within an organization to get together and sit down and take 10 minutes and do the scoring, and then have discussions about what you want to do with that.
All right, thanks so much for coming, Dr. Browning.
Thanks, Sue Ann.
A PDF document called Strategies for Incorporating 988. And what this is a combination of a lot of what we heard from the 5 providers that presented during this webinar series, a lot of the great conversation and interaction with you all that we heard. Some of the SAMHSA recommended best practices are also included, and we try to just pull kind of all the innovations and all the best practices that we've heard. The whole goal, obviously, of 988 is really to improve accessibility to crisis care and then get people linked. Investing in your workforce, we've heard a lot about that, and you heard Matt saying that that's on California's radar as well. Really pouring into your workforce, taking care of the helpers. Who is helping the helpers? Supporting your workforce. We heard a lot of great ideas from our 5 presenters. So this is a compilation of all of the 12 988 centers throughout the state of California. Got all their local phone numbers to the crisis line. Some of you also do 211, other hotlines, other types of services, mental health, substance use programs. The SAMHSA strategic plan for 2023 to 2026. Why did I put this on here? Because if you look, they've identified 5 key areas. And this first one right up here is enhancing access to suicide prevention and crisis care. And that's what we are all doing. That's our call to this work. When we talk about 988 and how to continue building out our crisis continuum, at the end of the day, it's meeting people where they're at. It is reaching people that are in a mental health crisis and getting them connected to care. And then the other piece here on SAMHSA's plan is strengthening the behavioral health workforce. And within this, there are some specifications around the use of peer support specialists. So I just wanted to call your attention to that. If you want to read that online, that's easy to find. Additionally, you may have heard that SAMHSA just in the last week or two put out the national model standards for peer support certification. They identified 11 model areas, such as what should the standards be around training? What should the work experience be? What about the examination process to become a certified peer support specialist, supervision of peers, etc. And then 3 types of peer certification: mental health peers, substance use, and also family peer certification. So a lot of states have a process and a mechanism for peer support specialists, for the training, for the exams, for the certification and supervision process. But SAMHSA has pulled all of that together, trying to put forth more of a national model, especially since the advent of 988. We did hear that some of you are using peers to do some of those follow-up and outreach calls. And I think that peers are very underutilized within the crisis continuum. And I think there's a lot, we're going to hear a lot more to come on that. And then lastly, just want to let everybody know that the 2012 National Strategy for Suicide Prevention and the Surgeon General's Call to Action, which implemented that, or which built on that in 2021, that is up for renewal. That was set to kind of guide our national strategy around suicide prevention for 10 years. So we're a couple years overdue. And there is a work group that's been put together and coordinated by the Department of Health and Human Services. It's an interagency work group to really identify and update and build upon those existing documents. Of course, back in 2012, we didn't know 988 was on the horizon. And so really this has been such a game changer for our country. And so to take a new look at that, you can expect to see SAMHSA releasing something around those guidelines, hopefully in January of 2024. A very gracious thank you to the 5 988 centers that volunteered to present and tell us about your work. We had started off with Buckelew programs. We heard from Contra Costa Crisis Center, Central Valley Suicide Prevention, Crisis Support Services of Alameda County, and also we heard from Didi Hirsh as well. I want to thank all of you for joining us. You can always reach out to the care team and they know how to get in touch with me if you have any follow-up questions or concerns. Thanks again.